Hey Phil.
Hello,
Hey, how are you?
not too bad.
Perfect. All right. What do you say if we kick things off?
Yes.
Perfect. So first of all, good morning, everyone. My name is Todd Simpson, and I'm the Marketing and Communications Coordinator here at Safe Work Laboratories. And we'd just like to say welcome and thanks so much for being part of the SW Labs Workplace COVID-19 Testing webinar. So joining us today, as you will see, is Dr. Phil Tynan, our National Toxicologist. Say hey, Phil.
Hello, hi guys.
And so now I'll just take you through how the webinar will work. So as you can see down the bottom, there is a chat and a Q&A function. So we just ask that any of the questions that you may have along the way or even at the end, please put them into the Q&A function. And we've designated some time at the end of this webinar to answer those questions for you. So without further ado, I might pop you over to Phil now.
Okay guys, today's talk's basically about coronavirus workplace testing. I think the slide should come up, hopefully. And let's quickly plunge into the history of coronavirus in this next slide. Now, historically, coronavirus is a single-strand RNA virus, and there's 7 strands, 4 of which 7 of these strains will cause the common cold in people. Now, historically, we've had 3 novel strains develop, and the first 2 occurred in the last 15 years, last 20 years actually, sorry. And these include the first one, which is the SARS, the Severe Acute Respiratory Syndrome, which was first identified in 2003 in Yunnan in China. Basically, it was a rather nasty pneumonic disease that was spread from bats to humans in the Chinese wet markets. Fortunately, it burnt itself out rather rapidly, and only, unfortunately, about 774 people died, but could have been a lot worse. Now, the next coronavirus that came to prominence was the Middle Eastern Respiratory Syndrome, MERS, which was first identified in Saudi Arabia in 2012. This was basically a coronavirus that went from dromedary camels to human. It was extremely nasty, with a very high lethality rate, which in a way was fortunate because this disease developed in isolated areas in Saudi Arabia, and it killed so rapidly that it failed really to take off. Now, there was a small outbreak again in South Korea in 2015, but the South Korean authorities managed to isolate it very quickly. And there's another small outbreak in isolated areas in Saudi Arabia in 2018, which also burnt out. Now, as you can see in this next slide, we have the third variant, which is coronavirus. And coronavirus basically is a severe pneumonia that officially began, at least in December 2019, in Hubei province in China, in the city of Wuhan. The first recorded death, officially at least, was on the 8th of January. Evidence from other Chinese sources suggests, in fact, there were substantial numbers of deaths around the beginning of December, and that the authorities were rather late in responding. It was originally referred to as coronavirus infectious disease 19, or COVID-19. The actual virus itself is SARS type 2, which is different, obviously, from the original Chinese variant, which was coronavirus 1. Now, as you can see in this new slide, coronavirus is substantially less lethal than the MERS or the original SARS. SARS had a case fatality rate, which means the percentage of people who get it who die, of about 9.6%. MERS had an absolutely appalling death rate of 34%. 1 in 3 people who get it died, which in a way was a blessing in disguise because it meant it killed before it could spread, which I suppose was good in a tragic way. Coronavirus has a case fatality rate between 2.3% and 2.9%, which is not good, but it's way less bad than the other 2 variants of coronavirus. Now, what's interesting is that 80% of all cases of coronavirus infection are either asymptomatic or very mild, so mild they don't need to go to the hospital or see a doctor. And so it's very likely that there's substantial under-testing, and it may mean that a lot more people are infected. And so the real death rate is probably a lot lower. It's probably the CDC, the Center for Disease Control in Atlanta, Georgia, says probably now a lot closer to that of a severe flu, around about 1% or so. Now, as you can see in this next slide, mortality rates are high. And what's happening is we have this constellation of symptoms. The symptoms include fever, cough, shortness of breath, and actually also, interestingly enough, the loss of a sense of smell. These can occur anywhere between the 2nd day of infection to the 14th day of infection, but overwhelmingly, in the vast majority of cases, will occur between the 5th day of infection and the 11th day. So between day 5 to 11, in fact, between day 5 to 9, more than 3/4 of people who are going to be symptomatic will be symptomatic. As you can see in this next slide, the fatality rate, which we've been talking about, it's low in young people. It really only starts to take off in people after the age of 50. Prior to that, the cumulative level is actually quite low. Now let's have a look at this next slide here. The important thing to remind ourselves is that 80% of people will recover from this disease without needing special treatment. This is not the Spanish flu of 1919. This is not the end of the world kind of plague. In some ways, people are somewhat overreacting. Let's have a look at this next slide. Who's at risk? Well, a lot of people may get infected, but those who are at risk of significant disease are largely the elderly. This is people over 65 years of age, anyone with an impaired immune system, anyone with a chronic lung, heart, or kidney conditions. Remember, some people may have these conditions and not know they have them. I've got bad news for you smokers, by the way, because you are at risk, and that, by the way, also includes people who vape. So vaping is not going to protect you in this case. And the other group affected are those who are poorly controlled diabetics. But again, 80% of people won't have any symptoms at all. And what you can do to protect yourself from this disease is basically to practice proper hand hygiene and wash your hands with an alcohol-based hand wash. Anything with 70% or more alcohol would be effective. It's important that if you're going to sneeze or cough, you practice appropriate hygiene, and you either use a tissue or you cough into your flexed elbow and sneeze into your flexed elbow. Avoid contact with anyone who's symptomatic, and if possible, it's often not possible in the workplace, you can wear a mask. The important thing is wearing a mask is not the be-all and end-all. It really functions mostly to protect people who are already infected from spreading their larger aerosolized droplets to the rest of us. It is not a major protective mechanism, nor is shutting down things. Next slide, please. I just want to show what the current situation is like. As of the 11th of October, we had 37,081,631 cases. That's a lot. Of these, 1,071,046 people died. That's a death rate of 2.88% of people who we know have been infected. But there's a big point here. The big point is this. Most infections we are not going to test because a lot of people won't present. Remember, 80% have either mild or asymptomatic cases, and so they're not going to be tested. And of those who died, overwhelmingly, most of those were either elderly or had pre-existing serious conditions. Let's have a look at this next slide and actually have a look at what this really means. Basically, the important thing about coronavirus is that it will have a large financial impact. Why? Because people are getting sick, there are shutdowns, and it's disrupting the normal flow of the economy. As of the end of the first financial quarter of this year, throughout the developed world, we had between a -15 to -5% drop in real GDP growth. The figure for China is mostly, to be honest, aspirational. I doubt the Chinese themselves absolutely know, but as an example, China normally posts something like a 6% per annum growth rate. It's now saying it's going to be less than 1.6%. The suspicion is that China's economy has actually substantially contracted, but the party is unlikely to admit that. As you can see, Australia wasn't too badly initially affected, but by the end of the second quarter, we had more than a 6% contraction. In some ways, this could be best summarized by looking at the travel figures. By the beginning of the mid of the second financial quarter of this year, we had had a 23% drop in transport numbers to Australia, and also to East Asia and Southeast Asia. This had a major impact. If you have a look at what this has done to the stock market in this next slide, you'll see that there's been a substantial drop in the stock market between March and April in all the major markets. What's happened since then has been a very patchy recovery. Even in the Nikkei, which had the best recovery of all, you still ended up by mid-July with things dropped down by -5.2%. Dow Jones -13%, and the FTSE in London is almost -20%. And remember, recovery such as it is from the low peak in mid-March is still very, very patchy indeed. And this is best exemplified by this next slide, which shows what the hiring rates are in many economies. Have a look at what's happened in Australia. Things started to plummet in March, and basically by July, by the end of June, beginning of July, we had something like a 22% drop in new hires by LinkedIn, and it hasn't improved since. As you'll see in this next slide, what we need to do is we need to have a look at the real health impact of this disease to get a perspective of what's going on. Okay, we can see it's heavily impacting the economy, but what are we really dealing with? What is the real picture? Well, fortunately, we've been given a real-world laboratory. I suppose only a scientist or a doctor would say that, but in a way it's true. We had the cruise ship Diamond Princess, which was quarantined off Yokohama in Japan. It had 3,711 people on board. Unfortunately, it used recycled shared air conditioning, so everyone was exposed over a period of a month. Now, only 17% of people got infected. That meant about 83% of people of the population are immune. 51.7% of the infected cases had no symptoms at all. That's none, zero. Okay, that's a bit high, as you'll see in the next slide when we get to it. The current rate of asymptomatic carriage is between 40 to 41%. The reason for this is that these are healthy people. The real death rate in the population from the disease is 0.5%. The death rate from infected non-immune people was 0.91%, and from symptomatic people, it was under 2%, 1.9%. So you can see in otherwise active people, people able to work, people able to travel, the real death rate is under 2%, and probably less than that, because quite a few of these people, remember, were elderly, and you know, they were able to take a nice retirement cruise. In a normally population distributed age range, the death rate would be lower. Let's have a look at the figures from the CDC. The average number of people that each infected person will infect, the so-called R0, is 2.5. So each infected person will infect 2.5 non-immune people. The death rate is critically dependent on the person's age, basically. If you're below 50 years of age, the death rate is less than 1 in 5,000 people. That's important to bear in mind. Less than 1 in 5,000. Okay? If you're between 50 to 60, the death rate is 1 in 200. And that's because you've got other conditions as well becoming prominent. If you're over 70, which is the big risk period, even there, the death rate is 5.4%. That's barely above 1 in 20. So you can see it's not the end of the world, but it is serious. What's really concerning, though, is that of all the infected cases, 40 to 41% are asymptomatic. Now, before you think no symptoms means no infection, no, that's wrong. If you're asymptomatic, you are 3/4 as infectious as a person who's coughing their lungs out. And that means an asymptomatic person will infect, on average, 1.9 people, let's say 2 people, you don't get 0.9 people in the real world, will infect 2 people around them. Okay, that's not much less than the 2.5 that a symptomatic person will do. And what's worse is that of those who become symptomatic, the so-called pre-symptomatic cases, half the number of people, the symptomatic people, will infect will occur prior to the onset of their symptoms. So obviously we have to pay attention to the symptomatic cases. Now let's have a look at the next slide. What's important is that, unfortunately, because we've been having good news for a while about coronavirus, people became complacent. Unfortunately, what we've noted is that when that happens, a lot of the testing and the hand washing and the social distancing starts to be relaxed. And as studies have shown, when they've tested for the virus in wastewater, we still have foci of infection, which we haven't addressed. Just recently, in the last 3 weeks, we've discovered wastewater. Studies have shown that there's infectious virus in the Hawkesbury, in southwest Sydney, and, for example, in Rockhampton in Queensland. That Rocky one's important because there are new cases in Queensland, and Rockhampton is a major employment feeder to the mines around the Bowen Basin. So, as you can see, we still have a problem. It's not just Victoria, it's New South Wales, it's Queensland, it's South Australia. Okay, now all of this leads to the problem of second wave infections. Because the Europeans believed that there was light at the end of the tunnel, and there was, they then far too rapidly decided to drop the need for testing. And as a result, cases have started to rise very rapidly once again in Italy, Spain, and England. In some cases, the rate of pickup is faster than the US, although in some of the American cases, the population density is higher. You'd expect it higher in the US, but because Europeans weren't testing, they've allowed this to happen. Now, as you can see in this next slide, the important thing to do is to consider the risk from asymptomatic cases. I just want to show you that this is a problem in Australia. This is a real case. This is what happened in the Casula Hotel in the west of Sydney. On the 30th of June, a truckie in Melbourne went to Casula. On the 3rd of July, he attended a party at the Crossroads Hotel for barely 3 hours, behaved himself impeccably, no problems. This guy had not, to the best of his knowledge, ever been around infected people. 12 days later, we already had 30, that's 30 cases of active coronavirus spread from him. We know that because we sequenced the virus. 10 were directly infected from the hotel, and 20 more cases from these secondary infections. In other words, 30 people from one case in under 2 weeks. Let's have a look at this next slide. What we need to do when we have to fight this virus is to flatten the curve. And the way to do it is that the way South Korea, Taiwan, and Singapore did it. Not China, because the Chinese figures are very rubbery and in many cases are rubbish. But what they did in South Korea, Taiwan, and Singapore, and that was they insisted on really obsessive hand washing, social distancing when it was possible, and extensive testing with rapid turnaround time. Nothing else, Masks where people could wear them, but a lot of this happened before there was extensive mask wearing. What was important is that they tested people, and they tested asymptomatic people where they thought there may have been a risk. Okay? And because of that, they were able to intervene rapidly and stop the spread of the disease. Now let's have a look at this next slide. This discusses what we call the 5 protections. This is what a workplace needs. Now, you can't apply all 5 protections in any situations all at once. That would be pretty difficult. The important thing includes things like keeping your hands clean. This can involve wearing gloves, but not every place are you going to be able to wear gloves. And other cases, people do wear gloves at work. They don't have to be surgical gloves. It's just something to protect you touching contaminated surfaces. Above all, far more important than this, is washing your hands. And that means washing your hands properly, washing it with 70% alcohol mixes, taking 20 seconds to do the full hand wash, not the dip it underwater, wave it in the air and hope it's clean behavior. Masks where it's appropriate, but masks are not that important in this case, just simply getting people, if they cough or sneeze, cough in a tissue or into their elbow. Maintain social distancing of about 1.5 meters where it's possible if they can, but above all, test people if you have suspicions or if you're in a risky environment, or just to maintain an assurance that your environment is clean. So next slide, let's have a look at what people are doing to test. The trouble is there's a lot of BS testing going on, and that's really worse than useless. The most common of these is forehead temperature testing with the infrared scanners, non-contact infrared thermometers. The trouble is these will only pick up people who actually have fever at the time. In other words, is symptomatic. I remember pre-symptomatic people who can be picked up by stuff like PCR will have already infected half of the people they're going to infect by the time they develop symptoms. Above all, this will not detect asymptomatic carriers who are still infectious, so it's pretty useless. There's another test going around. These are the point-of-care fingertip tests. These test for the antibodies you produce to the virus. The trouble is they don't detect the disease early enough to be of any use, and there are lots of false negatives. Many people are told you haven't got it when you do have it. This test will not tell you when you have the disease. It may only tell you that you've had it in the past. The gold standard is PCR, and it's got rapid turnaround. Let's have a look at what the college said about finger prick testing. Basically, they emphasized that not everyone will develop antibodies. And I'm not just referring to your old grandmother. Young, healthy people may still not develop antibodies, and this is a substantial number of people will not develop them. By the time the antibodies develop, it will be after 11 days. Now remember, overwhelmingly most people who become symptomatic will develop symptoms between days 5 and 9. So it's a bit late in the day. And developing it, as you can see, it rises over time. Most will have it by about day 20 if they're going to develop antibodies. That's already too late. The disease usually only lasts about 2 weeks. So all this will tell you, next slide, is that you've had the disease in the past, not that you may have had the disease in the past, but not that you are infectious at the moment or that you are carrying the disease. So the college's position statement, the Royal College of Pathologists of Australasia in September 2020, basically what we said was, if you're going to test, which you should use a PCR test. It's very reliable, very accurate, high throughput, rapid turnaround time, and it will tell you if you're asymptomatic carrier, if you've got the disease now, if you're infectious, okay, which is what you need to know. Knowing that, Joe Bloggs had it 2 months ago is irrelevant. You need to know now. So with the next slide, basically, what's PCR? PCR is where we amplify the presence of the genes of the virus. Because we're actually testing for the virus's genes, we'll be able to tell you that the virus is present there. We're not dependent on the response of the patient, of the donor. It tells us whether the virus is there. So it will tell us in real time if you have the virus, not if you're responding to it. Now, there's one other thing I want to raise up, and that's basically, as you can see in this next slide, basically what type of swab types do we have for PCR? This could be nasopharyngeal, which is the most accurate one. The only trouble with nasopharyngeal is it can be a little bit uncomfortable. It's not painful, it's uncomfortable, and it takes a bit more skill to do. It has the highest capture rate for the virus, roughly around about 95%. In cases where people can't do it, potentially you can test with oropharyngeal. This is throat swabs. These are easier to perform, they're better tolerated, but they only have about 80% the same capture rate as nasopharyngeal. I would strongly recommend nasopharyngeal done. If it's done properly, it's not that bad at all. It's mildly uncomfortable, but that's way better than having your workplace get infected and having to shut the place down. The issue about PCR is that it's gold standard and you have rapid turnaround time. If we get a sample, for example, by midday, we will have the result available for you and reported to you by 5 o'clock the same day. So that's basically 5 hours turnaround time at the most. Now, let's have a look at this next slide. What are future options? Well, what we're looking into for the future for you is to do testing in wastewater to see whether coronavirus is there. If you can isolate the wastewater effluent flow from your work site, which you may or may not be able to do, if you're an isolated work site, that should be easy, but you might be working in the city perhaps, in which case it's difficult. You can do what some of the health departments are doing, like in Queensland and New South Wales and the rest, and this will enable you to work out whether there are people with the virus present, and in that case, you'd want to do a bulk testing of your workforce, nasopharyngeal swabs across the board or throat swabs. Another test that we're developing is surface coronavirus testing. In other words, is the virus on surfaces that you swab and you send in to us for testing? Same turnaround times, by the way. Why is this useful? Well, because as you can see in this next slide, the trouble is coronavirus will survive on surfaces. On plastic, at least for 72 hours under all circumstances. Stainless steel, 48 hours. On copper, interestingly enough, copper is toxic to most viruses and it won't survive long at all, and you don't get viable particles. On cardboard, roughly 8 hours, 12 hours, very rarely up to 24 hours if someone coughs and sneezes directly onto it. That's very rare. What that means is your postal packages are safe. Let's look at what the CSIRO did recently. They then broke it down to the temperature effect. The higher the temperature, the shorter the survival period of the virus. It'll survive on cotton at 40 degrees Celsius for less than 16 hours. On your banknotes for roughly about 24 hours. So someone who's contaminated and who's coughed onto their banknotes, you may still pick it up from the banknotes. That's why, got to emphasize, at work, wash your hands. Okay, on vinyl, it will survive 48 hours at 40 degrees C. As the temperature drops, the time of survival increases. At 30 degrees C, it's 3 days for cotton. It's 7 days for your banknotes, and paper banknotes, 21 days. Interestingly enough, they didn't get any viable particles from paper banknotes beyond 17 days, but they could still detect fragments up to 21 days on paper banknotes. On the colored polymer banknotes we use, it's about a week. At 20 degrees C, it'll survive on cotton for about 11 days, actually. And it is detectable on banknotes, including polymer banknotes, for about 11 to 14 days or so. On paper notes, it's detectable for 28 days, but again, nothing viable after 17 days. So next slide, please. What this means is that you've got to consider the issue about contaminated surfaces. So what are the options for workplace? What's recommended is that you consider testing your asymptomatic fly-in, fly-out workers prior to arriving at a site. This is your optimal strategy. Always test your symptomatic workers and ensure that they socially isolate till you get the results. If there are local cases or you're concerned, or it's a good idea just to get a baseline to ensure that your workplace is safe, might be a good idea to institute some degree of bulk workplace testing. If, for example, your local wastewater effluent has been found by the health department to have coronavirus in it, might be a good idea to actually start testing some of your workers. Okay, and I've got to emphasize that because I am concerned that we may see breakouts further in Queensland, which we have, by the way. Whether they're Victorians, as some people are saying, who infected innocent Queenslanders, or whether they're people from Rockhampton, as some of my other doctor colleagues think is more likely, is an open debate. The politicians, oddly enough, seem to know magically that it's Victorians. Well, maybe they do. The other thing is, in future, test your work site wastewater effluent for COVID-19 if possible, and probably more practically, test surfaces for contamination by COVID-19. If it's present, simple thing to do is you then test your work site and you clean the site down. It's very easy to do. We can give you protocols for cleaning. Cleaning then will just simply means whoever cleans wears gloves, they have a face mask, and they spray the site down with something really cheap like ViraClean. ViraClean actually works, guys. And you don't need to saturate the place enough to make your nostrils tingle. You just really need to just wipe it down properly. Okay, that's it, guys. Any questions?
Fantastic. Thanks, Phil. I actually can't believe how long the virus lasts on some surfaces for.
Yes, it's a worry, isn't
Crazy.
it? So it was unsuspected by people, and that's why CSIRO decided to do the study, because people were getting infected for no apparent reason, and they started saying, well, no one's coughed on them, so could it be that, you know, they're picking it up from their hands? And by the way, you also can pick it up from your cell phone, so it's a good idea to wash them down too.
Perfect. All right. Thank you for that, Phil. We'll just stay on for another 5-10 minutes, just answering any questions that anyone might have. So yeah, feel free to please put them in the Q&A and we will answer them for you.
One of the interesting things about the disease is, again, although most people are asymptomatic, it's important to realize how quickly the stuff can spread. Now, I just got a question. Is it ambient temperature? Yes, guys, it is ambient temperature. One of the things to take home from this as well is if you want to clean something, it's very easy to do. If you've got clothes and such, use a hot water cycle. The hot water cycle will kill the virus. Your warm water is your friend. Okay, so hot water cycle in the washer will kill the virus. And yeah, these temperatures, unfortunately, are the ambient temperatures. So air conditioning may not always be your friend either. Not only will it spread the virus, but it may actually prolong the survival of the virus.
I think Mark Bush is putting his hand up, so I'll just allow Mark to talk. Mark, did you have a question?
Yeah, I'm intrigued with the mask and the commercial, I guess, manufactured mask, the cloth type ones. I'm intrigued as to how effective they are, especially if they're going to be washed in hot water considerably, a number of times. I've been told every 4 hours. The other side of it is, what does the washing, especially with detergents, etc., do to the material over a period of, say, a week or 2 weeks? Because most times when you wash your clothes, the material becomes thinner and thinner. So I'm just sort of intrigued as to how that sits. Thanks, from a professional point of view. Yeah.
Very good question, Mark. Very good question. Don't keep your mask for 2 weeks, please, because by the end of 2 weeks, I mean, they're a nice social signal. They may be a good fashion accessory, but that's about all they're good for. Regular washing will degrade the masks. The best masks are N95 and KN95s. These can't classically be washed. The ones with filters that you can exchange, these can be used as well. Cloth masks, if you wash them, ideally you should replace them every 3 to 4 days. Okay, and that's from the latest evidence from CDC.
Thank you.
So I know what many of the manufacturers are saying, but the evidence is after about 3 days, the protection starts to drop substantially.
Does that answer your question, Mark?
It does. That's good. Thank you.
No worries at all. Thank you. We've got now another question from Robert. And he asks, can an employer collect the samples themselves, or do they require a suitable qualified collector? Phil?
Well, nasopharyngeal would require a suitable qualified collector because it's unpleasant. However, throat swabs are not that hard to do, and we have a quick training package for the employer to look at.
We do.
And it's really just open your mouth. The first thing is swallow, okay? Don't have a lot of spit, phlegm, and gunk in your mouth. Swallow, maybe take a glass of water or whatever beforehand. Swallow, make sure your mouth is clean. Open your mouth, say ah, and someone then put the swab in, avoiding the tongue, and just basically wipe the back of the throat. That's all, very quickly, 5-10 seconds or less, and take it out. Do tell the person not to chomp on the swab. For whatever reason, I've actually had patients do that, and I don't know why to this day. The only people who you should be concerned about when you do a throat swab is if they've got dentures. I know it's embarrassing, but if they've got dentures, it might be a good idea to move your dentures.
Perfect. Thanks for the question, Rob. We might go to Natalie's next question. So for surface testing, is there a specific swab type, Phil?
For surface testing, we can we could supply the swab material that you'd need. Yeah, there's a particular swab type. That will be available in about 3 to 4 weeks' time. At the moment, it's not available generally in Australia. These methods are methods which have been developed overseas, and what we're basically doing is we're taking the Cyro method and we're just building it up in scale.
Perfect.
We already, for example, test for drugs in surfaces like methamphetamine surface testing. This is effectively the same kind of swab.
Perfect. Thanks for that, Phil. And thank you, Natalie, for your question.
And
we've got another one in the...
remember that
That's
you
right.
can do the swab yourself. The important thing is have it noted where you did the swab, because the major problem we've noted with people is that they don't note where they swabbed, and then it's a big question, where exactly was it that we picked stuff up?
So Phil, we've just got another question in the Q&A, and they're wanting to know what is the turnaround time on wastewater testing and who is providing this service?
Well, wastewater testing is something we will be providing. We're not doing it yet. We'll be doing it about 3 to 4 weeks' time. The turnaround time would be within the same day. Once we've got it, you get results within about 8 to 10 hours after we actually get the sample. So if you send it to us, we get it, you get it pretty quickly. Now, why is that an advantage? Well, if you do wastewater testing, on average, they've found it gives you about 3 days warning before whoever is shedding actually becomes symptomatic, if they're going to be symptomatic. If they're asymptomatic, well, it obviously gives you quite a lot of warning, because they're never really going to become symptomatic, are they? So on average, you get about 3 days warning, factoring in our turnaround time.
Perfect. Thank you, Phil. We'll go to Sabrina. So she has a question. Did you say the catch rate of the virus in oropharyngeal swabbing was 80% compared to nasopharyngeal? She wasn't sure whether you said 80 or 18%.
80. It depends on the study you do. Now, the CDC study did studies at 2 levels. Real-world studies, as opposed to everything controlled in the laboratory. Everything controlled in the laboratory, it's 70, that's 70%, okay, as opposed to 95%, it's actually 94.6% for nasopharyngeal. real world studies where it's not in the laboratory and you're actually collecting people out in the real world, not in a laboratory controlled situation. Everyone's wearing lab coats and, you know, everything's been done absolutely perfect. The figure is about 70 to 73.5%, very close to 75%. Sorry, what am I saying? Correction. It's, apologies, it's 75.3 up to 79%, in other words, 80%, 80% of the detection rate. So the general figure they say as a rule of thumb, it's 80% detection rate as opposed to nasopharyngeal, which is 95% detection rate. Okay, what's the problems here? It looks to be that most of the problems isn't actually with the collection method. It looks to be that if you swab a person who's only been exposed within the last few hours, you may not pick up anything no matter what you do, because the virus has just been absorbed in the system and hasn't started replicating. So, you know, if I, for example, cough on you and you suddenly get tested 2 hours later, every test on the planet is going to come out negative. If, however, you test a day later, then yes, we're going to start picking you up. So factor that in as well. What this means is that oropharyngeal testing is considered quite acceptable. Nasopharyngeal testing is the gold standard. There's another version which is very close to nasopharyngeal, and that's called mid-terminate testing, which is like nasopharyngeal, but instead of pushing the swab all the way in, you only go a little bit of the way in. It's much less uncomfortable than full nasopharyngeal swabbing. If you get the person to blow their nose prior to testing, and obviously wipe their nose, of course, let's not be grotty, what will happen is you get a pickup rate that is roughly about 90, that's 90%, and it's more comfortable than nasopharyngeal. Also requires less training than nasopharyngeal. So that's an option you can consider.
Perfect. Thank you for that, Phil. It looks like we don't have any other questions or any other questions in the Q&A. So we might wrap it up here. So thank you very much for everyone attending. We really appreciate it. And if you do have any questions regarding today's webinar, please let us know. We're going to be uploading it to our YouTube channel, so you can go back and have a bit of a look at it there. But yeah, if you have any questions, please give us a call. Thank you for your time today. Thanks, Phil.
Bye, guys.